Imagine the body as a complex building. Bones are the beams, muscles are the motors, organs are the working rooms, and connective tissue is the material that holds everything together. It supports joints, strengthens skin, helps blood vessels keep their shape, and gives many tissues the right balance of stretch and stability. In Ehlers-Danlos syndrome, or EDS, that support system is built differently. The result is not just being unusually flexible. It can affect movement, pain, skin, scarring, digestion, circulation, and, in some forms, blood vessels and internal organs. EDS is not one single disease, but a group of genetic connective tissue disorders. That detail matters, because two people with the same broad label can have very different symptoms, risks, and daily challenges. Ehlers-Danlos syndromes are currently classified into 13 types, a system last updated in 2017 when several rarer forms were added. The shared theme is a problem in connective tissue, often involving collagen or proteins that help collagen form, organize, or function. Collagen is sometimes described as the body's scaffolding, but it is more dynamic than that. It gives skin strength, helps tendons and ligaments resist strain, and supports blood vessel walls. When collagen or related connective tissue components are altered, tissues may stretch more than expected, heal differently, or fail to provide stable support. This is why EDS can appear in many body systems rather than staying limited to one organ or one type of symptom. The symptoms most associated with EDS are loose or hypermobile joints, joint pain, unusually stretchy or soft skin, and abnormal scar formation. A person may notice that their joints move beyond the usual range, that they sprain easily, or that they have frequent subluxations, where a joint partially slips out of place. Some people experience full dislocations. The skin may feel velvety or fragile, and wounds may heal with widened or unusual scars. These signs can be present from birth or become more obvious in early childhood, especially when a child begins crawling, walking, running, or participating in sports. But symptoms can also be subtle, dismissed as clumsiness, growing pains, or simply being double-jointed. Hypermobile Ehlers-Danlos syndrome, often shortened to hEDS, is one of the most discussed forms because it is relatively common compared with the rarer types and because its genetic cause has not yet been identified. That makes hEDS unusual among EDS types. It is diagnosed clinically rather than confirmed with a specific genetic test. People with hEDS may have generalized joint hypermobility, chronic musculoskeletal pain, recurrent joint instability, fatigue, and related symptoms that affect daily function. For some, hypermobility looks like a party trick. For others, it means constant monitoring of posture, careful movement, braces, pacing, and pain management. The visible flexibility can be only the surface of a much broader condition. EDS is genetic, but the inheritance pattern depends on the type. Mutations in one or more of 19 known genes can contribute to different forms of EDS, and the specific gene involved often determines the subtype. Some forms are inherited in an autosomal dominant pattern, meaning a person may develop the condition after inheriting one altered copy of a gene. Others are autosomal recessive, meaning two altered copies are usually required. In some cases, the genetic change is new, arising early in development rather than being inherited from a parent. These mutations commonly affect the structure or processing of collagen, or related proteins such as tenascin. The end result is connective tissue that does not behave in the usual way. Diagnosis can be straightforward in some forms and frustratingly difficult in others. For most EDS types, genetic testing can confirm the diagnosis by identifying a known disease-causing variant. But for hEDS, there is currently no confirmed genetic marker, so clinicians rely on medical history, physical examination, joint mobility criteria, skin and tissue features, family history, and exclusion of other conditions. This can lead to long diagnostic journeys. Some people are initially told their symptoms are psychological, or are misdiagnosed with conditions such as somatic symptom disorder, depression, or myalgic encephalomyelitis, also known as chronic fatigue syndrome. While these conditions can coexist with EDS, mislabeling physical connective tissue symptoms can delay proper support. One reason EDS is often misunderstood is that many complications are invisible. Chronic pain can develop from joint instability, repeated microinjuries, muscle overwork, or early osteoarthritis. When ligaments do not stabilize joints well, muscles may compensate by staying tense, which can create fatigue and pain. Scoliosis, or abnormal curvature of the spine, can occur in some people. Repeated sprains, tendon irritation, and joint injuries may accumulate over time. A person might look healthy while carefully avoiding stairs, long standing, certain chairs, heavy bags, or sudden movements. Because the condition can fluctuate, a person may manage one activity on a good day and struggle with the same task on another day. Some types of EDS carry especially serious risks. The forms that affect blood vessels can weaken vessel walls and increase the risk of life-threatening complications, including arterial rupture or aortic dissection. An aortic dissection happens when a tear forms in the inner layer of the aorta, the major artery carrying blood from the heart. This is a medical emergency. Not everyone with EDS has this level of vascular risk, which is why accurate subtype diagnosis is so important. The prognosis depends heavily on the specific type. Some forms are compatible with a normal life expectancy, while vascular forms generally reduce life expectancy and require specialized monitoring, prevention strategies, and emergency awareness. There is currently no cure for EDS, so treatment focuses on support, prevention, and symptom management. Physical therapy is often central, but it must be tailored carefully. The goal is usually not to push flexibility further, but to improve strength, coordination, joint control, and safe movement patterns. Bracing or taping may help support unstable joints, especially during specific activities. Pain management may involve medications, pacing strategies, heat or cold, and treating related muscle tension. In forms involving blood vessel fragility, blood pressure medications may be used to reduce strain on vessel walls. Treatment works best when it is individualized, because the same exercise or brace that helps one person may worsen symptoms in another. Daily life with EDS often involves balancing protection and participation. Complete inactivity can weaken muscles and make instability worse, but overexertion can trigger pain, injury, or prolonged flare-ups. Many people learn to plan around energy limits, use adaptive tools, choose lower-impact exercise, and avoid movements that place joints at risky angles. Education is powerful. Understanding that pain may come from instability rather than lack of effort can change how someone moves, rests, and seeks care. Schools, workplaces, and families can also make a major difference by recognizing that accommodations are not special treatment. They are practical ways to reduce injury risk and preserve function. EDS affects at least 1 in 5,000 people globally, though some types are much rarer and estimates vary because diagnosis is uneven. The condition has been observed in different forms for centuries. Excessive mobility was described as far back as Hippocrates in 400 BC, long before modern genetics could explain why some bodies moved and healed differently. The syndromes are named after Edvard Ehlers and Henri Alexander Danlos, two physicians who described key features around the turn of the 20th century. Today, research continues to refine classification, search for the genetic basis of hEDS, and improve care. The more EDS is understood, the less likely people are to be dismissed as merely flexible, fragile, anxious, or unlucky. The key idea is that Ehlers-Danlos syndrome is a connective tissue condition with many possible forms, not a single symptom and not simply extreme flexibility. It can affect joints, skin, scars, pain levels, spine alignment, blood vessels, and long-term mobility. Some people live with mild symptoms, while others face disabling pain or serious vascular complications. Diagnosis depends on recognizing patterns, identifying the subtype when possible, and using genetic testing for all types except hypermobile EDS, where the marker remains unknown. While there is no cure yet, supportive care can reduce harm and improve quality of life. Understanding EDS starts with seeing connective tissue as essential infrastructure, and recognizing what happens when that infrastructure works differently. If you found this helpful, please like this video and subscribe for more explainers.